Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, everybody. It's my honor and pleasure to continue our lectures of 100 golden rules of supraventricular tachycardia. How can we assess and induce tachycardia? And how can we reach a diagnosis of all types of supraventricular tachycardia, AVNRT, AVRT, atrial tachycardia, using all diagnostic maneuvers to reach the diagnosis. Today I'm going to tell about the atrial overdrive basing, one of the most important, powerful diagnostic maneuver to reaching the diagnosis, and how can we use it to differentiate all types. Let's start our lecture to tell about the main concept of the overdrive basing. Today we will discuss the overdrive basing from the atrium. How can we do the atrial overdrive basing and entrainment? As we discussed before, to do the overdrive basing we should have ongoing tachycardia. Then we start basing slightly faster than tachycardia cycle length to be able to entrain and overdrive the circuit. Then sudden stop of basing and let the tachycardia continue. This is the main concept of overdrive basing, to tell in narrow complex tachycardia how beneficial the atrial overdrive basing to differentiate AVNRT, AVRT, atrial tachycardia, not only supraventricular tachycardia. Also, it will help us so much to differentiate all types and the hard dilemma, challenging scenarios in wide complex tachycardia. Is it VT, antidromic tachycardia, accessory pathway, or just SVT with aberrancy? Is it critical situation like VT, we have to give daisy shock if patient unstable, then go to ICD and VT ablation, or just it is SVT with aberrancy, I have to go to ablate just slow pathway or accessory pathway? Which of which? Then we will see how atrial overdrive basing is much useful to guide us. The checklist of atrial overdrive basing. Tachycardia should be there. Base the atrium at 10 to 40 milliseconds faster than tachycardia cycle length. Stop basing and confirm tachycardia continue. When you base, you should base from the atrium and make sure consistent atrial capture. Then the most critical step, you should identify the last accelerated and captured His and V. And as we know, when we do the overdrive basing, the most powerful diagnostic maneuver, we have three main zones: initial, transitional zone, upstream fusion, then constant capture, maybe progressive fusion, and finally the return zone. After we stop the overdrive basing, the return zone is the most important zone from which we will have many data that we should interpret. And today we are telling about many findings in return zone. Atrial overdrive basing assessment and interpretation will help us in 6 challenging different scenarios. We have to assess return zone, return pattern, to differentiate between AVNRT and junctional tachycardia, AHA or AHHA response. Also, in wide complex tachycardia, is it VT or SVT with aberrancy? Is it AVA response or AVVA response? Also, we will assess the last entrained sequence to differentiate all types of SVT. Then we will assess stem to H minus AH interval more than 40 milliseconds or not. Then also it will help us in flatter post-basing interval minus tachycardia cycle length, and finally VA linking concept. Now let's go to the first scenario in which we will see the atrial overdrive basing basing from high right atrium, then assess the post-basing response. It will help us so much in a golden rule to differentiate AV-NRT from junctional tachycardia, a common scenario that we have to know how our approach. AV-NRT, go for slow pathway ablation, mandatory. However, in junctional tachycardia, no need to ablate more and more, just a medical treatment. Both of them are narrow-complex tachycardia, 1-to-1 conduction with very short VA interval. So how can we discriminate? When we start atrial overdrive pacing, then stop it, we will find the response. Junctional tachycardia, AHA response. AV-NRT, AHA response. Really, a golden rule when we assess the post-pacing response. In supraventricular tachycardia, junctional tachycardia, AHA response. AV-NRT, AHA response. Confirm diagnosis, just ablate slow pathway. Here, this is the illustration and the concept of atrial overdrive pacing in junctional tachycardia in the top panel and AV-NRT in the bottom panel. We can appreciate in junctional tachycardia we have a focus, and when I start overdrive pacing, I am not able to interrupt the tachycardia. That's why the response AH, then waiting for new trigger HA response is AHA response. In AV-NRT, it's a different scenario. We have AV-NRT circuit, a slow pathway, fast pathway, limbs, it's re-entry, and when I start the atrial overdrive pacing, I will interrupt the tachycardia. So the response is AH, then retrograde HA. So it's HA response. This is the main concept that we have to know. Good. Let's go an example to illustrate atrial overdrive pacing in junctional tachycardia. Here we can appreciate narrow-complex tachycardia. Short VA interval. Start atrial overdrive pacing from high right atrium. Stop pacing, we can appreciate a HA response. Definitely it's a junctional tachycardia. Let's go to the second scenario of AV-NRT. We have a narrow-complex tachycardia, 1-to-1 conduction with VA interval very short. Start atrial overdrive pacing from high right atrium. Stop pacing, we can appreciate AH response. Definitely it's a case of re-entry circuit, AV-NRT, go for slow pathway ablation. Let's go to the second scenario in atrial overdrive pacing, return zone. How beneficial atrial overdrive pacing is helpful in challenging scenario, wide complex tachycardia. We have to assess the post-pacing response to differentiate, is it VT or not? In case of VT, the response AVV response. But in SVT, with aberrancy or antidromic tachycardia or duodromic tachycardia, dual accessory pathway, response AV response. However, in AV-NRT with aberrancy, occasionally we can see AAV response, and please don't confuse about the pseudo AVV response. You should illustrate very well the last based atrial beat and the last accelerated V beat. Golden rule in wide complex tachycardia: use atrial overdrive pacing, assess post-pacing response, mainly to tell is it VT or not. In VT, the response will be a VVA response. However, in SVT with aberrancy antidromic tachycardia, it will be AVA response. Main concept, again the same concept of re-entry circuit. I can interrupt, so it's AVA response. And this is the illustration to understand in VT. It's AV, VA response. However, in SVT with aberrancy, I will find AVA response. Let's go to overdrive basing. In this example of VT, at the right side of tracing, I can appreciate wide complex tachycardia with very short HV interval minus value, negative value. I am dealing with VT likely. Let's go for atrial overdrive basing. Stop basing. Response is AVV, A response. Definitely it's VT tachycardia. One more thing we can highlight, there is a change in QRS morphology between tachycardia and the basing. Also, HV interval normalized when we start atrial overdrive basing. On the other side, what about atrial overdrive basing in AV NRT with aberrancy? I can appreciate in the right side of the tracing wide complex tachycardia, right bundle morphology, long VA tachycardia 1 to 1, and HV interval is long. Let's start atrial overdrive basing, and we can appreciate after stopping the basing AVA response. It is not VT, it's SVT with aberrancy. We can appreciate QRS complex morphology almost the same, tachycardia and the basing, and the HV interval almost the same. It's an amazing illustration of SVT with aberrancy and how atrial overdrive basing is beneficial to confirm. Golden rule in atrial overdrive basing: the critical step, you should distinguish between the last based atrial beat, the last captured ventricular beat, which will have RR interval equal the atrial basing cycle length, to rule out pseudo AVV A response. In this example, we have a case of wide complex tachycardia starting atrial overdrive basing. From the first site, we can tell the response AVV A response, but if we focus and concentrate, it is pseudo AVV A response. It is not VT. Why? Look at the last atrial based beat, this one, then the next last ventricular capture beat. So this based beat have captured this ventricular beat, so the response is AVA response. And to confirm this, look at the cycle length, 340. It is the same that we base at 340. Still, we are dealing with one of the most powerful diagnostic maneuver, overdrive basing from the atrium. Let's go to the third scenario in which atrial overdrive basing will help us to differentiate all types of SVT, to assess the last entrained sequence. One of the amazing tools that we can use in narrow complex tachycardia to tell, is it AVNRT, atrial tachycardia, orthodromic reciprocating tachycardia. Start atrial overdrive basing, stop, assess the last entrained sequence. What happened at the early atrial activation sequence, AHV? What about the sequence? Definitely in atrial tachycardia it will be orthodromic conduction, and the sequence will be A2 then HV 100%. If the response is AHV, I'm dealing with a case of atrial tachycardia. In orthodromic reciprocating tachycardia, it will be HV A2. In a typical AVNRT, response is HV A2. In typical AVNRT, it will be HA2V. And this is the main concept. You have to assess the second atrial electrogram after stopping overdrive basing, assess the earliest atrial activation sequence, AHV. Okay, and this is the main concept and illustration in which we can illustrate the conduction of the last entrained beat and how affected the sequence in reentrant atrial tach. We can tell A2, then H, then V, AHV. What about the last entrained sequence in atypical AV-NRT fast slow? HVA2, similar scenario as orthodromic reciprocating tachycardia. Finally, in typical AV-NRT slow fast, it is HA2, then V, and occasionally it may be HVA2. Let's see some illustration and examples. A case of atrial tachycardia. Basing in the top panel from CS, the bottom panel from high right atrium. Stop atrial overdrive basing. What about the response? A2 HV, 100% a case of atrial tachycardia. Let's go to another example. Atypical AV-NRT. Start atrial overdrive basing. Stop. What is the response? We can appreciate it is HVA2. It's atypical AV-NRT. Let's go to orthodromic reciprocating tachycardia. It's the same scenario. HVA2, 100% accessory pathway mediated tachycardia. Let's go to the last example. In the typical AV-NRT, we can appreciate HA2, then V. And I advise all of you to review the amazing paper in novel diagnostic technique for atrial tachycardia to differentiate it between all types of supraventricular tachycardia through the last entrainment sequence. It was published in JACC in 2022. Still, we are discussing the amazing rule of atrial overdrive basing. Let's go to the next scenario to assess stem to H minus AH during tachycardia. In AV-NRT, we will find the difference more than 40 milliseconds. However, in AVRT, it will less than 40 milliseconds. Next scenario, how powerful atrial overdrive basing will help us in flutter. When we want to assess, we are close to the re-entry circuit or we are far, we will find the post-basing interval in flutter less than 50 milliseconds if we are right-sided atrial flutter, the common cavo-tricuspid isthmus dependent flutter. However, it will be more than 50 milliseconds if it's a typical flutter left-sided. And this is the gold standard algorithm to diagnose the flutter, then assess the post-basing interval when we do atrial overdrive basing and entrainment. If we do successful entrainment in flutter, assess the post-basing interval less than 50 milliseconds. It's a typical atrial flutter. We are dealing with cavo-tricuspid isthmus flutter. Let's go to the last scenario in which atrial overdrive basing will help us. The concept of ventricular atrial linking, VA linking, to differentiate between all types of SVT. We have to do atrial overdrive basing from different sides, high right atrium and CS catheter. Then assess the VA interval following last entrained QRS complex. If I have VA linking, what does it mean? The VA interval less than 14 milliseconds in differential basing. It means I have VA linking. AV-NRT, AVRT are likely. However, if no VA linking, VA interval more than 14 milliseconds when I pace from different sides, I'm dealing with atrial tachycardia. And this is the concept when I illustrate the difference overdrive pacing, and I will find there is VA linking in orthodromic reciprocating tachycardia and AVNRT. Why? Because in accessory pathway tachycardia, the antegrade limb AV node, retrograde limb accessory pathway, so I have fixed relationship between ventricle and atrium. Same scenario in AVNRT, slow pathway, AV and accessory pathway, I have fixed relation between V and A. That's why there is VA linking in ORT and AVNRT. In atrial tachycardia, it's a different scenario. No fixed relation between V and A in atrial tachycardia, so no VA linking. So VA interval will change more than 14 milliseconds. This is amazing illustration of atrial overdrive pacing, differential pacing. First panel from high right atrium, second one from CS. Assess VA time after stopping the pacing. It's fixed. It's a case of AVNRT. There is VA linking, fixed VA interval. But it's a different scenario in atrial tachycardia when I pace firstly from high right atrium, then from CS. Assess the VA interval after stopping. In the first panel 174, second panel it's 250. There is no VA linking and the VA interval change more than 14 milliseconds with differential atrial pacing. Thank you so much. We reach to our conclusion today. We have a powerful maneuver called atrial overdrive pacing. Thank you so much.